Hello and welcome everyone. My name is Ellen Hostetler. I'm the Chief Science Officer for the John Ritter Foundation, and we are here today to have Final Friday with an aortic disease expert. And I know you all are really excited for today's agenda because we're going to be talking about an update on research in aortic disease and have Dr. Milewicz, who many of you of course know very well, give us a presentation on that. To start with a few just quick notices, we are going to record this, or it is recording rather, and we will post the recording on our website and on our YouTube page, so you can share it with your friends and family or anyone else you care to who may not have been able to join us today. And our past recordings are also available there, so you can view the previous experts that we've had. And other than that, I think we're going to get started. The chat on the window there is available for your use to say hello and ask questions. We will be getting to those. There will also be some polls throughout the talk, so it'll be obvious when those are happening. We'll point it out, and if you'd like to answer those, that would be great. We're going to try a little bit more interactive session today, which I'm really excited for. But first, I wanted to play a quick video featuring a person who is very close to the John Ritter Foundation and his story about participating in research and what is meant to him and his family. So I will put that up quickly, and then we will, right after that, we'll get started with Dr. Milewicz's presentation.
Hello, my name is Greg Weaver, and I live in Austin, Texas. Why am I here today talking to you? Well, I've got quite the family history of aortic aneurysms. My grandfather passed away of aortic aneurysm at the age of 52. My uncle at the age of 26. My father passed away at the age of 42, all three of them of aortic aneurysms. Then about 15 years ago, my brother at the age of 36 discovered he had an aneurysm. The good news is he caught it and they were able to replace it. And not only were they able to replace it, the cardiologist at Stanford Medical Center, Dr. David Liang, advised our family to get into a research program run by the John Ritter Research Institute at the University of Texas Houston Health Science Center, a program run by Dr. Dianna Milewicz. So what happened? Well, so they take our DNA, and they took all the DNA from all of our descendants or family members who were alive. They actually took my brother's aorta as part of the DNA sample, and all of that was entered into a research program. So what was the purpose of the research program? It had nothing to do with our family. It was really our family giving to science and giving to aortic health science to help discover the genes, to help to understand what causes these aortic aneurysms that impact so many people all over the world, so many families, generation after generation like ours. And again, that was about 15 years ago. So what happened from there? We were told at that point in time, we'd probably never hear back from anybody, that this was all about research, had nothing to do about our family or them finding a gene or impacting us. Well, 3 or 4 years ago, I get a strange phone call from a Houston phone number. I don't pick it up. The person leaves a very, very long message. As you can see on your iPhones, how long a message is. And I'm like, well, that's interesting. So the next day I checked the voicemail, and it was one of the genetic counselors from the Houston Health Science Center, someone who worked for Dr. Milewicz. And unbelievable, they found the gene. They found the needle in the haystack that has caused our family so much grief for so many years. And what does that mean for us? Well, that means for us, like for myself, I'm the first male that doesn't have the gene in 3 generations. It's unbelievable. And now my 2 boys, who are 22 and 18 years old, they don't have the gene. And so on our side of the family, we've broken this. My brother, knowing that he did have the gene, his family now, one of his kids has the gene. And the great news is now they can track him. And he should never have a fatal impact of an aortic aneurysm. But more important, than our family is for all the other families out there and all the other people out there that now the gene is being discovered and being found. So this aortic aneurysm should not be a fatal health impact, where people can live long, healthy lives, even though they may have the gene. It can be tracked. It's amazing. So anyways, all this research has a significant impact to so many different people. Our family was a beneficiary of it after a lot of tragedy, and we're super excited that now through this research, many more people and families will be impacted in a positive way. Thank you very much.
Thank you so much to Greg for sharing your story. I love your message, and I love your willingness to be such a great ambassador for participating in research and what that can mean for the family, as well as the wider community of people with thoracic aortic disease. So without further ado, I am going to go ahead and introduce our expert today, because I know we're all eager to hear from her. And I'm going to go ahead and read some details from her bio, just because it is so extensive that I want to make sure I get all the details correct here. So Dr. Dianna Milewicz is the President George H.W. Bush Chair of Cardiovascular Medicine, Director of the Division of Medical Genetics, and Vice Chair of the Department of Internal Medicine at the University of Texas Health Science Center at Houston. This is also known as UT Health or McGovern Medical School. She has forged a career in translational studies focused on finding the genetic predisposition to vascular and aortic diseases. She is using her expertise to inform gene-based clinical management treatment of aortic and vascular disease. And along the way, she has saved the lives of people who carry one of these genetic changes that puts them at risk for higher risk for thoracic aortic aneurysms and dissection. And she and her team are responsible for the discovery or identification of many of the genes that we know today can put someone at risk for thoracic aortic disease. So if you've had genetic testing and you've seen that long list of letters and numbers and gene names that's on that report, many of those were identified by Dr. Milewicz and her team. So we have them to thank for that, and we know that they're working hard on finding more of them. So I'm going to go ahead and turn off my mic then and let Dr. Milewicz take it away from here.
So I'm going to give you a brief update where we are in terms of finding the genes that predispose people to thoracic aortic aneurysms and acute aortic dissections, but just talk about the research in general, and what will come out of this talk, I think, is that there's a lot that we don't know about this disease, and we really need to make it a priority going forward to learn more about how to manage the disease, how to manage the consequences. Not just, we know so much about the aortic surgery and how to do that successfully, but not how to prevent those dissections. We're still not there. And then what happens after the dissection in terms of everything from what exercises you can do, what issues about mental health after dissections, and so on. So I want to take a big step back and say, where are we going and why are we trying to go there with the research? So let me see if I can advance the slides. Okay, I want to start out by just getting everybody on the same page. So on the left-hand side is, can you see my pointer? Can you see the pointer? No, okay.
Sorry, I do not see a pointer.
Let me, okay, I'm just gonna say, just one point then. On the left-hand side is a normal aorta. In the middle is an aortic aneurysm. Most of you know an aneurysm is just where the aorta enlarges, and that enlargement tends to be totally asymptomatic. We can go in and repair the aneurysm, and we do that to prevent the acute aortic dissection. And that's where the blood enters the wall and tears the wall apart, and that can cause sudden death. And even if you survive the dissection, it is emergency surgery and there's a risk of death. And it ends up being a chronic dissection after the surgery, and there's complications related to that. So the whole focus of the John Ritter research program that I direct is to prevent aortic dissections. And so once again, we'll be talking about how we do that. And the number one way that we do that right now is we find out who's at risk. We image the aorta and watch for aortic growth. We give them drugs. We have 2 drugs that we can give, beta blockers or ARBs. Those are angiotensin receptor blockers like losartan. But the mainstay is to repair the aorta, typically when it reaches about 5 centimeters. And with that, we can prevent those dissections essentially 100%. We can't prevent the dissections that involve the descending aorta, which are called type B dissections, but those tend to be less deadly than type A dissections. So when I set up to talk about this condition and how we go about studying various aspects about it, I went to a research study that was run by Dr. Shireen Shalhoub at the University of Washington, where she involved aortic dissection survivors from around the world and asked them what their priorities, both research in terms of management, what their priorities were in terms of thoracic aortic disease. And here's a list of those priorities: genetic predisposition. When do we go in and repair that aneurysm or enlarged aorta? What are the medications that prevent disease, and why don't we have better medications? Exercise. What can you do if you have an aneurysm? And what can you do after a dissection, and how much exercise can you do? And then once again, those mental health issues that really do affect the quality of life of people with thoracic aortic disease. In addition, they were very concerned about patient and physician education on thoracic aortic disease, and why can't we use telemedicine to better manage this disease? So we're going to go to our first poll of the audience out there. And, the next slide shows what our research priorities, and we'll talk about these during this this presentation. So Ellen's going to do her first poll to get an idea of what your priorities are. So if you just go ahead and answer this, then we'll see out there what you as a group, do you match up with the priorities given in by the aortic dissection survivors.
And I think hopefully my audio is a little better now, folks. One thing to note is, of course, these all may be priorities for everyone. So, these are all important, and it's just about ranking them. So, of course, we know that many of you probably care about all of these things.
So it looks like genetics is winning. Yay. But exercise is close behind. So we are going to talk about genetics and exercise during this talk. The other 2 issues are very important for preventing dissections, and we would love to get to medication that completely prevents growth and dissection of the aorta, so that people don't have to go and have that major cardiovascular surgery. So thank you for your participation. Are you going to do a seminar on exercise?
Yes, we will be. Yes, absolutely.
Okay. So in preventing aortic dissections, I just want to take a step back and talk about what are those major risk factors for thoracic aortic disease. And it really comes down, in terms of what we know, to these 3 areas. One is anything that increases the forces on the ascending aorta is the number 1 risk for aortic disease. And number 1 on that list is hypertension. If you take patients that come in with aortic dissections and ask them about hypertension, 90% of them have a history of hypertension or come in with hypertension at the time of diagnosis. So it is a big risk factor. And other things that increase pressure, like very heavy weightlifting, cocaine, illicit drugs like cocaine and methamphetamine that make your heart sort of hyperdynamic and push and contract harder and more frequently. And then pregnancy increases the risk just because the blood volume goes up in women that are pregnant by a third. So you have just a lot more blood hitting that ascending aortic wall with every heartbeat. And then number 2 is the genetic variants in our genome that we get from mom and dad that predisposes to this disease. And we've known that for over 50 years, closer to the 70 years. And we know that if in people with Marfan syndrome that have an alteration in just one gene in the entire genome, and typically just one base pair change out of 3 billion in the human genome, that if it falls in that FBN1 gene, it causes Marfan syndrome, where they're 100% likely to get aneurysms and dissections in their lifetime because of that one base pair change. And now we know there's other syndromes that predispose to the disease. So we've known for a long time that the genetics play a prominent role. And we figured out it's not just Marfan syndrome by taking family histories of people with aortic aneurysms and dissection, and 20% of people without Marfan syndrome have a history of disease. And then we know some congenital heart defects like bicuspid aortic valve and patent ductus arteriosus can cause an increased risk for aortic disease. And then more recently, we found out that a specific antibiotic called fluoroquinolones also increase the risk for aortic disease. And we still don't quite understand that risk, but we're recommending anybody who has an aneurysm or is dissected not to take this class of drugs. It's an antibiotic that's commonly used for urinary tract infections and so on. And it sometimes can be used chronically. So if you talk to your doctors, if you are on this medication, or are prescribed this medication and you have a risk for thoracic aortic disease. So here are the risk factors. And my work has really focused in on those genetic variants, because if we can look in the human genome and pick out the variants that predispose people to disease, then we can identify people early, monitor them for aneurysms, send them to surgery, and prevent aortic dissections. And so now I'm going to switch over and start talking about that genetic risk and what we know. So I've already talked about Marfan syndrome. That was an original hint that genetics played a role in this disease. And we went on to show that 20% of the people that didn't have Marfan syndrome had a family history. And in those families, aortic dissection risk is typically passed from one generation to the next. And somebody has a 50-50 risk of passing it on to each and every one of the children that they have. And Greg talked a little bit about the risk in his family. His brother got the genetic variant, but he did not. And so in a family, if you know it's running in the family, it becomes very powerful information. Because first of all, we can do genetic testing to find the actual defect, but we don't know all the genes yet. But then we can just image everybody for aneurysms, because typically there's some enlargement of the aorta prior to dissection. So just through imaging, even if we don't know the gene, we can find people that have aneurysms and begin to monitor them. And then take children and families like this one. So here's a pedigree. Men are square and women are circles. No surprise that men are squares. And if they're filled in, they've had aortic disease. And you can see this father passed it on to this son and this daughter. So although sometimes it can look like mostly men are affected in the family, the women also can be affected. So keep that in mind. And then as they pass it down, there's a 50-50 risk that each child will get the variant. And that's because you have if we take the FBN1 gene, everybody has 2 copies of that gene. One they get from mom and one from dad. And in these diseases like Marfan syndromes and in families where genetic predisposition is inherited, it's typically inherited due to alterations of just one of those genes. So when you go to have your children, you can pass on the normal gene and presumably get a normal gene from the other parent, and the child would not have a risk of thoracic aortic disease. But if you pass on the altered gene and get a normal gene from the other parent, then the child has inherited that risk. It's very simple genetics, so that you can use that in a very powerful way. So we've been using families like this one to really go after all the genes. And we're going to do another poll right now and just ask this audience, how many of you have two or more members in your family with thoracic aortic disease, either aneurysms or type A, type B dissection?
Dianna, or Dr. Milewicz, sorry. One quick question that came up here that I think is really important to emphasize is if you do know what the genetic cause is in your family and you do not carry it, so for example, in Greg's story where he shared, he does not carry it, are his children still at risk? Do they need to be tested? Like I say,
if he has two normal genes, he can't pass on to the next generation. And in that arm of the family, the risk ends. It goes back to the population risk for disease, and that's still there, but it's so much lower than inheriting one of these altered genes. So I think we're a little bit skewed towards people with the family history. I'm glad to hear that. But so welcome. And I want to say this is the list of genes that most of them have been identified by my lab, but also identified by other labs around the world. And despite having this long list of genes, we can only solve about 30% of the families. So that means in about 70%, we don't know the gene yet. But if you have a family history, everybody needs to be imaged to make sure they don't have an aneurysm, because those tend to have no symptoms whatsoever. So keep that in mind. And we're still trying to identify all the genes and working towards finding them all. And I just want to stop and say, why is a genetic diagnosis important? It is because we can identify other people in the family at risk and put them on medical protocols and surgical, do the management so that they prevents the dissection. And we right now are pushing a gene specific management. So you get that specific gene, and that tells us how to manage your family. And I'll talk more about that in a minute. But just remember, if we don't find the genetic risk, that we can identify family members at risk for thoracic aortic imaging just by doing imaging of their aorta. We can find other family members at risk. Also, in people that don't have a family history, the current treatment guidelines recommend that all the first degree relatives have their aorta image, just to make sure we're not missing a strong genetic predisposition. So that means if you've had an aortic dissection, your parents should be imaged, your siblings should be imaged, and your children should be imaged. So keep it in mind, we can still use this to prevent dissections in other family members. So we're going to do...
Dr. Milewicz, can I interject to just ask a few questions that have come up about those slides? So a good question that someone had is, in that family tree you showed, is that when people talk about colloquially skipping a generation, does that mean that where you showed one person who was not colored in, and then but their kids, some of those children were colored? Is that what that is talking about?
Okay, so I'll go back to that family. There's something called decreased penetrance that can occur in a family. And so here we had a family where the grandfather was affected. He passed it on to two sons that had dissections. He also passed it on to one of his daughters. because she went on to have children that both had dissection. Now, she herself went well into her 80s without disease. And she ended up dissecting a completely normal aorta at the age of 84 in her dancing class. So she ultimately had the disease, but sometimes in women it can be much later onset, or they end up dying of other causes, and that's called decreased penetrance. So it turned out she finally, I need to go back and rescore this, but she finally did end up with disease, but it was much later onset than both of her children dissected at the age of 27. And her daughter most likely dissected because she got pregnant with twins.
Okay, that is very helpful. And someone else asked about, do spontaneous genetic changes ever actually happen?
Yes, they do, and they can be quite common. And something like for Marfan syndrome, the estimates are that 25% of the people with Marfan syndrome they have a new change in the gene. That means mom and dad were normal, but when the DNA was copied to make the sperm and egg that come together to make the baby, that there was a mistake made in the FBN1 gene, and that individual has that mistake and has Marfan syndrome. And once they have that mistake, in the next generation, it's a 50-50 risk of passing it on. So they do occur, and for some conditions, it can be pretty high, and others, it can be pretty low, and we're still sorting through that.
So even if you were the first person in your family to have this, it's still important to think about your children, even if you don't have, neither of your parents had the condition.
And I want to talk about the John Ritter research program. As I said, our goal is to prevent death and disability from acute aortic dissections. And we have a big emphasis on understanding the genetics and understanding why dissections occur. If you participate in our research, it costs nothing to you. You can do it completely from your house. You'll talk to somebody in our group they'll go through the study and get your consent to participate and your consent to let us look at your medical records in terms of just your aortic disease. And we currently have over 1,120 families in our study. And like I said, we've solved about 30 to 40% of them. And if we do solve your family, we'll let you know what your genetic variant is. So Greg was in our study, and we always say, we can't promise we'll find an answer, but we'll try as hard as we can. And we did identify his gene and get back to his family. And so now they know. So if you're not participating in our research, please contact us. Here's the email address, or you can go through the John Ritter Foundation. It's important to remind everybody that people that connect with the John Ritter Foundation and have questions about genetics, they are shunted over to our research program in Houston. And if you did get genetic counseling from us, hopefully it helped you. And then we do referrals for geneticists in your area or in your country to be able to get genetic testing and screening for your family members. Participation in a study is not clinical genetic testing. We're a research lab, and if we did clinical genetic testing, we'd have no money left over for research. And like I said, we have a lot more genes to identify, and we want to spend our money finding the rest of the genes. So as we identify genes, we have the companies and the laboratories that do the clinical testing add those genes to their clinical testing. And we really prefer that you have that clinical genetic testing before you enter our research program. Some people can't get access to it or don't have the funding. And in many countries, it's not easily accessible. So if you can't get it, we'll still take you in. And if we find a gene, like I said, we'll come back and let you know. Okay. Is that clear enough, Ellen? Okay.
I hope so, but if anyone has questions, I'm going to add in the chat a link to our website, which has information about how to find a geneticist or a genetic counselor, and some telehealth-based options as well.
Okay, now I'm going to talk about the bigger picture of aortic dissections. What I've talked about up to here are those 20% of the patients with the disease where it is being inherited in the family. And those are those mutations or pathogenic variants that confer this high risk and get passed from generation to generation. But there's a lot of people, the majority of patients, in fact, this is the other 80% of the patients that don't have a family history and have much later onset disease. So if you look at somebody with Marfan syndrome, if they're undiagnosed, the dissections occur in the late 40s. For familial, those people that look completely normal, like John Ritter's family and John himself, they present on average in their early 50s, but this later onset is up in the early 60s. And Richard Holbrooke, who was the Undersecretary of State to Hillary Clinton during the Obama administration, is an example. No family history. He did have a bicuspid aortic valve, and he had a dissection in Hillary Clinton's office and died a few days later after emergency surgery. So how do we find those patients, and how do we prevent dissections in those 80% where they don't really have any clinical evidence, like a family history or syndromic features that will allow us to identify them in the general population? And we've been working on that. And we actually want to really also gear up on this end of the research spectrum. So what we think is happening in somebody like Richard Holbrooke is that he has a genetic predisposition, but it's not a high-risk gene. But if he goes if he's in the right environment, that triggers the dissection. In this case, we think that environment is actually primarily hypertension. If somebody has significant hypertension that's poorly controlled, that can be the second hit, if you will, that causes aortic disease. But there may be other hits out there or environmental triggers that we don't know about. Like I said, we just learned about the fluoroquinolones. And so we had no idea that they actually triggered disease until research data started slowly coming out over the past 5 or 6 years. And there's probably other environmental triggers that we don't know, because the aortic dissection is actually increasing in the population. There's now been 2 countries that have countrywide medical records where they can look and really accurately diagnose aortic dissections in the patients that come into the hospital. And the 2 countries have already shown that aortic dissections are actually going up in the general population. So we have to know not only what the genes are to prevent those 80% of dissections, but what are those environmental risks. So we've been working on this, and our sort of phase 1 studies was just taking people that are young at the age of dissection to kind of really go after really bad risks that don't run in families, but really cause young dissections, and then doing exome sequencing of those cases. And we've done that, and we put them into programs that use artificial intelligence and machine learning and Bayesian models of genetic analysis. I know a lot of this doesn't mean a lot, but we can start using this to say, can we come up with a genetic risk score for a dissection? So right now, this is what it looks like. If our data didn't predict dissections at all, it would run just straight across, and this value would be 50. So now we're up to 70, But what we want to do is have a curve where it's up here, and this value, the area under the curve, is 95%. So we have a way to go, and we have what we want to do now is take those people with dissections and really get detailed environmental data and expand the number of patients and do whole genome sequence and sequence the entire genome and not just the exomes, which are where the genes are, and put all that data into machine learning and along with additional data so that we can hopefully push that curve up and come up with a genetic risk score that involves both genetic risk and what specifically are those environmental risks. So look for that study. We hope to launch it by 2023. We will have a number of major aortic centers participating in this study, and we already have the UK involved in this study also, so that we can take their data and match it with our data to sort of validate what we're doing. So be watching out for that. And like I said, what we want to be able to do in the future is sequence somebody's genome, you know, at a young age, and then sit down and advise them that they're at increased risk for dissection, and then be able to put them on a protocol to prevent that dissection, you know, what they can do, what drugs they can take and can't take, and so on. And I just bring this up. This is just this year in February, and this group from Stanford that and Baylor that also involved NVIDIA and Google were able to sequence an entire human genome and analyze it in just 5 hours. So I think that this will rapidly be taken up by medicine in the next 10 years, and that whole genome sequencing will be the future of medicine. That will be part of your medical record and part of how we move from treating disease to preventing disease. And I think as aortic dissections are the #1 disease we should be working on to determine the genetic predisposition, because it is a disease we can completely prevent the deaths, but if we know who's at risk. And I want to remind you that our current data that says that somebody that has a type A dissection, they only have a 50-50 chance of even making it to the hospital. And once they're at the hospital, it's another 20% risk of death after that. So this is, and this can be completely prevented. So that's why we really want to move rapidly on this project, so that when we move into whole genome sequencing for everybody, that we have the data to go in and say who's at risk and who's not. Because it just breaks my heart every time I hear of a family losing a loved one to aortic dissections. Okay. So just a few comments about those other areas of research. Why do we want people to exercise? Well, this is data from the American Heart Association. If you look at people with increased amounts of just aerobic exercise, walking or any physical exercise, the risk for all cardiovascular disease dropped dramatically. It's like exercise is taking another pill for cardiovascular health. And the data for mental health looks very similar to this. So keep that in mind. And so what are we talking about? Exercise and how much that, we know for people with thoracic aortic disease that aerobic exercise is recommended, and we want you to avoid isometric exercises. So go ahead and Google those. Isometric exercises include those where you're straining against something like push-ups, or what are these called? Chin-ups or something like that. I forgot what they were called. Whereas aerobic exercise is swimming, swimming and walking and things like that. So we don't have much exercise data for patients with thoracic aortic disease. I hope Dr. Siddharth Prakash does the seminar for you because he has been collecting a lot of data on patients with thoracic aortic disease and what happens to their blood pressure as they exercise. So he's beginning to find what more carefully what patients can do and what they can't do. So look for that data coming out, and I hope he's able to do the seminar. Right now, we're going to recommend the American Heart Guidelines to prevent cardiovascular disease. The goal is 150 minutes of moderate exercise a week. And that means getting out and walking or swimming or something, bike riding, at least for 30 minutes, at least 3 to 5 times a week. 5 times if you want to reach this goal, but at least 3 times a week. That's not a lot, guys. That's pretty modest. It can make a big difference. And I know I have hypertension. It runs in my family. And I know that if I am out there like swimming every night during the summer, I can go off of my blood pressure medicine. But as soon as I stop swimming, I have to go back onto medications. So it does make a big difference. And I really would help patients because it does have an effect of lowering blood pressure. Okay, another poll. We're not going to ask you if you do this or not, but we're going to ask what prevents you from exercising.
And maybe nothing does because you're already getting your recommended exercise.
I hope so. Well, it looks like worrying about damaging your aorta is way up there. So we have to do that exercise seminar and have, I know that our Dr. Prakash is getting ready to publish that data, and he will be able to go over it and really provide you hard data as terms of what can be done and what you should be doing and what you should not be doing. So really, really important. Thank you, everybody.
Yeah, it's almost 60% of people feel that way. So this is obviously a huge need.
So medications to prevent disease. Well, we have beta blockers and those ARBs like losartan to slow the growth of the aorta. That's it. They don't prevent dissections. And we have nothing that really completely prevents the progression of the disease. We've got to do better. And I'm happy to say that we recently got a very large grant from the Leduc Foundation to really look in animal models and in humans with dissections to really figure out why the aorta dissects. We know about beta blockers and ARBs because of studies in animal models where they slow the rate of growth. And then we have some studies in humans that they do that in humans also. But even in mice, we do not have good drugs that completely prevent dissections. So we've got to understand those molecular triggers so that we can begin to design better drugs. So I hope 5 years from now, I can come back and say, we have this drug. It's going into clinical trials, and we'll let you know if you can participate, okay? We've got to do better. In the meantime, control your blood pressure. That is the best thing you can do for your aorta. Take your medications, monitor your blood pressure. Everybody with thoracic aortic disease should be checking their blood pressure. I recommend you do it first thing in the morning because during the night, your blood pressure naturally goes down, and then there's a big bump up right before you get up in the morning, and you need to make sure that where that bump is. And most dissections, if you look just around the world, most dissections occur when that blood pressure goes up right before you get up in the morning. So you really want to make sure that it's not going too high right then. Okay, and then talk to your doctor. That upper number of your blood pressure is above 120. So usually you'll get 2 numbers, and normal is considered 120 over 80. So if it's going, and we want people with thoracic aortic disease to be well under that 120 mark. So let's get it down. And then finally, the mental health issues. We know that having an aortic dissection can trigger post-traumatic stress in the patients and in the family members too. And that we don't really, We don't know exactly how much that affects the quality of life or how to help people through that. And we really need a lot more research on the mental health issues. There's no doubt about that. So this is something that I think the John Ritter Foundation is very interested in addressing in the future, and will probably be through fundraising and donations, hopefully in the next year or two, be able to call for research applications that look specifically at this issue. It's so important for all of the families. Okay. We have another poll. I'm going to talk now about patient and non-research issues, the patient and your doctor education. So here's the question: which would you prefer? Get educated by your doctors, or get information from experts through the JRF to share with your doctor? Or both? And both is winning by far.
Both is running away.
I love that. I want you to be advocates for your own disease, and this is really good. Okay. So, and that is the JRF this is part of the mission going forward. So that is exactly it. So doctors' education, I was on the committee that wrote the first thoracic aortic disease treatment guidelines ever in 2010. So that was quite a while ago. And I'm happy to say we just finished the updated guidelines, and they should come out in the next 6 months. So everything's been updated, and there's a lot of big changes in terms of genetics and a lot of big changes in terms of how to repair the aorta using stent graft or non-invasive techniques where they don't have to do open surgery, but can repair parts of the aorta using grafts. So all of that is in the updated guidelines. No updates on medications. As I said, we're still sitting without more medications, but that will be coming out, and the JRF will be pushing that information out to physicians. This is such important information. The American Heart and the American College of Cardiology, plus a list of all the other medical societies, from the Society of Vascular Medicine to the cardiovascular surgeons and so on, they sign off on these guidelines. So all these medical societies sign off so that they become the standard of care. So what is in these guidelines is the way you should be treated by your doctors in terms of frequency of imaging of your aorta, when to go in and repair, what to do about blood pressure, and so on. So it's all in there, and I'm so happy that we're updating them, because there's so much new information in terms of the genetics and those stent grafts for repairing the aorta. And going back to why is genetic diagnosis important, I mentioned that we are working on gene-specific management. And we're doing this through an international consortium called the Montalcino Aortic Consortium. Here's the list of people, the group of people that launched this. And we now have thousands of patients in this database. We get people take their patients with mutations in the genes we know about, that long list that I showed you, and they put in the clinical data. And then we can use that to look at outcomes from aortic disease and start making recommendations on how to manage the disease. And I have to say, the Genetic Aortic Disease Association of Canada has stepped up to fund this through, in part, the Timothy Family Foundation, and we're really grateful to them. And I just want to show you that why this information is so important. So here are 3 genes that cause aortic disease. And if we look at, here's the age of onset of aortic events in individuals with alterations in those genes. And here's the probability that they're going to have an aortic event, which we describe as surgical repair of an aneurysm or presentation with a type A or type B dissection. So the age is on the bottom, the risk of having an event is on the left. So if you look on the left-hand side, there's 3 different genes. So most of them there is little to no events in children except for with that green gene. So we know for that green gene, we got to start managing those patients in childhood. But the other ones, we can wait until they're in their late teens. And then if you look at the average age, the blue line, which is PRKG1, those individuals start having events they're in their 30s. Whereas if you look at the orange line, which is MYLK, they on average don't have events until their 70s. So this has big implications in terms of how often we image them. How do we manage their aortic disease in terms of going in and managing the aortic aneurysms and going in to repair them? And just as an example, this is a family. I'm just going to talk briefly about this family because we're almost out of time. This is a family where the father died of dissection. The mother, who's on the right-hand side, she had 3 children. And we found an alteration in the PRKG1 gene. So dad had it and died of dissection at around 30. All 3 kids inherited the variant. And we know this causes early onset dissections. That's shown on the right side. And the pink is aortic dissections. And they tend to dissect with no enlargement. So what do we do about this disease? So one of the brothers, before we made the diagnosis, had already died at the age of 23 of a dissection. We were following the 2 other kids, and one of the boys had a normal aorta, was switched from beta blockers to losartan, and had a dissection 3 months later and died at the age of 19. And that's why for PRKG1, ACTA2, and MYLK, we're recommending beta blockers. Well, actually, for our patients, we're recommending beta blockers over losartan. And so here's a mother, lost her husband and 2 children to dissections. And here's her 17-year-old daughter with a mutation and a normal aorta. And we made the decision working with the patient and her mother to go ahead and repair her aorta at the age of 17, a completely normal aorta. But she did great and she's doing fine. And this is her after the surgery, not immediately after, but a few months later. So this is how knowing the gene and what's going on with that gene, and the fact that lots and lots of people have dissections and die with this particular variant under the age of 20, that we now can use that to be very aggressive about the management, where we wouldn't do this with FBN1, we wouldn't do this with MYLK, and so on. So it can make a big difference. And then patient education, you all are all on this talk. All y'all are, I'm from Texas, are on this talk because you want to be educated. And the John Ritter Foundation is really stepping up into that arena to provide this education. And thank you, Ellen and Amy and Meredith, for doing that. So just, and one last thing before we finish up, we have lots and lots of people in my group that do all the work and the research we did. And I want to mention Ellen Hostetler. Some of you already talked to her about research. She used to work for me, and unfortunately she moved and we couldn't continue to employ her. But the John Ritter Foundation was very lucky to have her running their scientific and patient information programs. And once again, happy to have you participate if your family's unsolved in the JRP research. We'll be launching the aortic dissection research, like I said, by the fall. And then if you have a mutation in a known gene, please participate in MAC, and you can do that by this email here. And we are so grateful to our funders, some individual patient funds, but in particular, the John Ritter Foundation, and then obviously a lot of money from the NIH, and also the American Heart Association has stepped up to really start funding this. But the John Ritter Foundation has been supporting our genetic research for the past 10 years and have been a consistent supportive. So thank you, and I'm happy to answer any questions in the last few minutes that we have. I went way over, sorry.
It was such good information, though. I think people are really excited. We do have a ton of questions for you, so I'm going to put you on the spot and ask you if you will come back to answer questions so that we can get to more of these in the future. Just because I don't think we can do them all in the next 3 minutes, but really quickly, let's see if we can get through 2 or 3. Okay, this is a great one. If the gene is known in the family and people do not carry it, do they still need to be imaged?
They still have a background risk, but we don't image the general population.
Okay, and then a few people asked a similar question to this, which is, aside from we know about the thoracic aortic aneurysm, we know about aortic dissection, are there other risks associated with these different genes, other diseases that people should worry about? Someone specifically asked about stroke.
So this is really one of the reasons we're pushing gene-based management. So when you go from gene to gene, you have that risk for thoracic aortic disease and dissections. But with specific genes, there's also a risk for other vascular diseases. For instance, with many of the genes that cause a syndrome called Loeys-Dietz syndrome and involve TGF-beta signaling, those patients are at a risk to have aneurysms and dissections of arteries other than the aorta. So we have to image them from their head down to their pelvis to look for those aneurysms on a routine basis. And how often they occur and where they occur vary from gene to gene. So we're trying to get all that data out from MAC and get that out into the into clinical care. And then with another gene called ACTA2, they have a risk for cerebral vascular disease and stroke. And they also have an increased risk for early onset heart attacks. So it varies from gene to gene, and it really, really emphasizes why we have to go to gene-based management for this disease. And I have to say that the American Heart agrees with us, the NIH agrees with us, and so they've been very supportive of these initiatives. And I've been working with the American Heart Association to really make sure this information gets out through them also, but also to help us get the gene-based treatment guidelines written and approved by multiple medical organizations. We'll be going through the American Heart to get all those approvals with the John Ritter Foundation help. Yeah.
That's really exciting to think about that future. I'm sure many people on here are looking forward to that day. Okay, the last question I'm going to ask is just a general thing, because a lot of people are asking about specific genes, which is amazing. We have someone on here asking about MFAP5. Yeah. We have some really, people are really clearly pretty knowledgeable and educated on what's going on with their genetics. Can you just briefly discuss what the difference between the genes that we know can cause thoracic disease are and some of these ones that we're investigating, and what it might mean to get some of these rarer ones that we didn't discuss as much in your talk?
Okay, yeah, this is one of those difficult issues in doing this research. Yes. So I'm going to go back to that very long list. Okay, so this is a list we have so far, and like I said, maybe up to 30% it explains the families, and so we have a long way to go because there's so much genetic heterogeneity. And that just means there's a lot of genes in the human genome that can be altered to predispose to this disease. And that's why I think we really need to start pushing machine learning and artificial intelligence to get to them faster than we can. So what happens is when we find a new gene, we have sufficient genetic data to say that it's most likely disease causing. So it's going to be running in our families. And then sometimes we do some other studies like make a mouse model to show the mice have aortic disease and things like that. But so we can publish that, but then it goes out there, the gene gets on those diagnostic panels, but we need additional data beyond one lab to confirm that it's disease causing. So you at least need another lab to come forward and say, yes, we have these same results with our families. And that sometimes takes a long time because there's so much genetic heterogeneity. So we're getting ready to publish a host, like 4 new genes in the next few months. And they'll go on these panels and go on this list, but they may not be validated for another few more years. So of all these genes, there's only 11 of these genes that are validated. We're going to meet again to go back and recheck these genes, and hopefully we'll validate a few more in the next 6 months. But it's just a very slow process. And the reason it's so slow is we don't want to come to you and say, this gene is causing the disease in your family. And this, you can use this to say who needs to be imaged and who doesn't. And then we could be wrong. And then somebody dies of a dissection. We just don't want to be providing the wrong information to the families, to each and every one of you. But our goal is to have an answer for every single family. And so it just takes time.
Yeah. Okay, with that, I should let you go because I know how busy you are, but we got you on the hook to come back and answer the rest of these questions. And I know a lot of people are asking specific exercise questions because, of course, we saw in the poll that was a big question. And like Dr. Milewicz said, we are going to have Dr. Prakash on later this year. He's really done some amazing work in this area, and so he will be the person to ask all of these to and be able to answer your questions a little bit more specifically. But do take a look at our website because we do have fairly detailed information on there that he helped us put together. So those recommendations about exercise and lifestyle, there is some info on there. We just, of course, need more. And with that, thank you so much to Dr. Milewicz for being here and taking your time to share all of this very, very exciting research with us, and to just learn from you. You're truly helped so many people in this community, and I did love working with you, of course, and I spent 7 years working in Dr. Milewicz's lab and loved them all and learned so much. And I'm happy that I'm able to continue working with her and the rest of this community and these researchers in my role with the John Ritter Foundation. So stay tuned, and thanks again to Dr. Milewicz.
Thank you for inviting me, Ellen, and thank you everyone for attending. Okay.
Take care.